Hello, welcome to Facebook Live at CGH. I'm Dr. Bill Bird. I'm the Chief Medical Officer here at the hospital. And I'm happy to have you with me today, Jeff Wright. Jeff is, what's your official title?
Physical therapist and manager of outpatient rehab.
Yeah, so he's kind of like, he helps run the show on the outpatient side of things in our rehab services. So I wanted to do something a little different in terms of another service here at the hospital, and I think you're going to find that what you hear from Jeff, you're going to be surprised the different things that we do in our rehab services here at the hospital. So stick with me on that. I will also say that because of the storm this week, our internet connection, I hope will hold on for this whole time, but there is a chance that we could go off, and if we do, hang with us, we'll get back as soon as we can. So I don't know how many of you have been disrupted by that, but I can, Dana and I can personally speak. We live a block or so from each other, and we haven't had power, so it's been interesting. So I tried to polish up as best I could, without the power here. All right, so all those preliminaries to say welcome, and let's get asking Jeff some questions here. So Jeff, let me see what I said here. Oh, yeah. Can you kind of explain what rehab entails? Because it's kind of a broad term, but when you think about rehab and you think about the department that you're part of, what does that mean?
Well, I think our vision, if you look back over the last 5, 6, 7 years, has really been to develop a comprehensive rehab department. So rehab would be PT, physical therapy, occupational therapy, and speech therapy. 5, 6 years ago, we started out with just an inpatient rehab department with all 3 of those professions, and then we had a single outpatient center. And over the course of the last 3 or 4 years, we've expanded to a couple different satellites. We now have a pediatric-specific rehab facility with each of those disciplines as well. So from a PT side of things, our focus with physical therapy is on just general functional independence. So we'll see post-operative patients, chronic pain, acute pain and strains, neurological rehab. We have some pelvic health providers now, lymphedema. So some specialized programs, but the general gist is functional independence with your daily activities, community activities. Occupational therapy, they will also focus on some of those activities as well. General cleaning, like around your house, bathing, dressing yourself.
I always thought of OT, so they do that kind of like functional stuff around the house.
Yep.
And I've also I always think of OT as like from the shoulder down, and is that?
Yeah. On the outpatient side, PTs and OTs, we kind of share the shoulder. We share a little bit of the elbow.
Share the shoulder. All right.
But our occupational therapist, the primary one at the Locust Street outpatient facility, Karen, she will treat fingers, hands, wrists, obviously the elbow, and then, like I say, we share the shoulder a little bit. So,
okay.
But really,
you don't have any shoulder fights or anything like that.
No, and it could be left shoulder PT, right shoulder OT.
Is that the more specialized than left shoulder?
Yeah.
Got it.
So,
okay.
But in general, OT is going to look at more like fine motor, dexterity, work, occupation related.
I know, like in my practice, we used to send folks over to get like evaluated whether they're fit for like a wheelchair.
Mm-hmm.
Is that OT?
Yeah,
okay.
OT, but PT can also help with that as well. So.
Okay.
It really depends on what the patient's having the most trouble with. So,
okay.
Is it more OT? Is it better served by OT, or is it better served by PT? And it is a comprehensive approach that we take. So, some patients actually will benefit from multiple disciplines for the same impairment or limitation they present with.
Sure. Did I cut you off on the speech therapy side of things?
No. So,
okay.
So speech therapy, as the name implies, is going to work to treat vocalization, so impairments of vocalization, articulation, but they're really good at also working with like feeding impairments, swallowing. So here at the hospital, we perform video swallow studies for those that are having those type of troubles. They also work a lot with cognition and memory, and so That can be in the elderly population, but it could also be sports related, so sports concussions, or just concussions in general. Speech therapy can help with that too. So
Good.
yeah.
And as always, those of you who are listening, feel free to send us questions. We'll be glad to try to take those on as you send them. And send them as soon as you can if it's related to physical therapy for Jeff, so we make sure that while he's here, we get a chance for him to answer those. Yeah, I want to delve in this a little further, Jeff, because we're pretty fortunate to have as robust a rehab department as we do.
Mm-hmm.
And we have some pretty specialized treatments that we do over there, that you do over there in rehab. So I'm going to list the ones I can think of, and you may have some others, but
Okay.
I want you to kind of tell the folks who are listening too, what these different treatments entail. So
Okay.
the first one that came to my mind was called lymphedema. You want to talk about what it is and what you do to treat it over there?
Yeah, definitely. So lymphedema, I guess the simple way to describe it is it's a condition where fluid accumulates within the body. It's most commonly in the arms or the legs, but you can actually accumulate fluid on your body in any part of the body. And so we have 2 certified lymphedema therapists here at CGH. They work both on the outpatient side and the inpatient side. And really the treatment for that is to develop strategies to minimize that swelling so the body can process the fluid, helps with mobility. Obviously it's going to help with your cardiac and pulmonary function as well.
Yeah.
Some of that is wrapping with like ACE bandages or lymphedema wraps. We also work with some companies that provide pumps for home, mechanical pumps. So
Yeah. So if you're someone or you know somebody who walks around all the time with really swollen legs and your doctor's tried everything they can to try to help you out and you're just not getting there, or the treatments that get you there have enough side effects that it's just not worth doing them, I would definitely keep in mind what our rehab services can do for that lymphedema. I know the other thing that I often see with folks, that their legs get so swollen they'll even weep because of the pressure. That's something that's right up the alley of these folks to be able to try to take care of it for you. So keep that in mind, a good service that we have. I don't know the fancy word for it, but I would say pelvic dysfunction. Can you talk about what we do for that, Jeff?
yeah, definitely. We call it pelvic health, and I guess traditionally the thought it started with like a women's health program for pelvic pain, low back pain, and it has grown. So we actually have a pelvic health therapist now that works with us over on the outpatient side. Pam Kapp is her name. And so what she works with specific populations would be for stress or urge incontinence, urinary incontinence, fecal dysfunction, pelvic pain, which could tie into back pain.
So like if you leak stool.
Yes, yeah. Definitely.
Literally.
Or have trouble passing a bowel movement as well.
Okay.
And also sexual dysfunction too. So Pam has done a great job over the last couple years of going to different continuing ed classes to specialize in some of these, I guess, smaller areas of pelvic health,
Yeah.
and that's enabled us to create more of a comprehensive program. So
Yeah. So I mean, if you're someone and you leak from either one of down below, or you have problems with pain or anything like that in the pelvic area, your docs are good at trying to help with that too. But if there's also an option there in rehab to try to help with that as well.
Mm-hmm.
So good service, and it's a service that we're pretty unique, I think, in a small community hospital to have that service. So
very.
please be aware of that. Next one I wanted to ask you about, Jeff, is dry needling.
Yeah.
That's dry needling. It's a hard word for me to say, needle. Go for it.
Yeah, so the official term for dry needling is actually intramuscular dry needling. It's a form of treatment where we use single-use disposable needles that are essentially inserted into the skin and into the muscle. The idea behind that is it's an effective treatment for trigger points, muscle tension, mechanical imbalances related to muscular structure. So we have a therapist over on the outpatient side, Allie Yem, who is specialized and certified in dry needling. We've been providing this service maybe a year and a half, 2 years now.
Yeah.
So it's the dry needling is a component of the physical therapy process too. So usually dry needling is applied, and then we also follow that up with stretches or strengthening or some type of other procedure to maximize the benefit of that.
Would there any typical conditions that someone would come to see Allie for that would fit a dry needling?
Trigger point and muscle tension is probably the most common. Usually it's in the upper trapezius muscle, so
Okay.
I think it's pretty common. Curious stress on your shoulders. That can lead to neck pain, shoulder pain, migraines and headaches. So like I say, the dry needling is a modality that we can use in conjunction with stretching and strengthening, and some of the other modalities we apply to get the best benefit in the shortest period of time.
Yeah, good. How about big and loud?
Big and loud is a fun one. It's really exciting. So big and loud, LSVT big and loud is a specific treatment intervention for patients with Parkinson's disease. So as Parkinson's disease progresses, what we see clinically is that patients begin to have slowed movements or smaller movements, smaller speech. And so big and loud is, as the name implies, it encourages big movements and loud vocalization. So it's a combination treatment by PT and speech. PT working on the big movements, speech working on the vocalization. And then we've actually expanded big and loud to another program we have now. It's called POWER, which is Parkinson's Wellness Rehab.
Okay.
So as patients transition and graduate from the big and loud program, POWER can be used for either kind of a continuation of what you're doing, like not necessarily maintenance, but just a higher level function. Or it's really beneficial for those that are just recently diagnosed with Parkinson's. They're not having the true movement related impairments, but they still want something to maintain their health, maintain their mobility.
Yeah, great program.
Very.
How about, let's talk a little bit, give me a thumbnail about PEDS Rehab and what we're doing out there with PEDS Rehab.
We're doing a lot of great things out there.
Which, by the way, PEDS Rehab, where's that at?
So the Pediatric Rehab Center is 2600 North Locust Street in Sterling. It used to be the old DeVita Dialysis Center. So we moved out there last spring, it was. And we've been out there. Like I said, we have PT, OT, and speech therapy. The approach there is the same as the rest of our rehab department. So we look for comprehensive care. There's a lot of sharing, communication across the disciplines. Usually we assess the patient for basic milestones based on their age. So we see kids from birth all the way up to 18 years old out there, complete an assessment, and then depending on where they are on milestones, what they're having the most trouble with, then we come up with that comprehensive plan to help treat and get them moving around a little bit better.
Yeah, it's a really cool facility.
Very.
I don't know, I haven't gone to other facilities, but it strikes me as something that, once again, is pretty state-of-the-art for if you had a child that needed these services. So.
And actually, before we got in, before we opened the new building, the pediatric group was over in our main outpatient building at 1809 Locust Street, which worked great with the smaller staff that we had, but kids obviously need individualized, specialized care. Treatment for a kid looks different than a 20, 30, 40-year-old. So getting them off to their own facility just helps the kid get into more of a natural environment that's play-based. And we've really seen some strong outcomes with the transition to the new centers.
Yeah. How about sports med? What do you guys do with sports med?
So sports medicine is actually one of the programs that we've had kind of going on for quite some time now. It's a cooperative effort with CGH Orthopedic Group here. So sports medicine, in the simple terms, would be treatment for sprains, strains, overuse type of injuries. But then again, we also see kids who end up with some type of major injury that needs reconstruction, and then we treat them post-operatively to get them back to their prior level of function, both academically and at home, but also sport-wise too. So.
Yeah.
And then in addition to the orthopedic side, we also work with neurology here at CGH for the sports concussion program. So, it's been one of the big hot topics the last 4 or 5 years now. And so we can perform baseline concussion testing, and then obviously post-injury concussion testing, transitioning kids back to not only academic performance, but also back to their sporting performance. So.
Yeah, so I think that's really interesting. So I always think in terms of, like, you have to have a neurologist or someone like that but you work with them.
Yeah.
And you can kind of manage a lot of that there in that clinic.
Yep. And similar to the other programs, it really is a team approach. So, neurology is involved, but so is the primary care doctor. We work a lot with the counselors or the teachers at the school, administration at schools, making sure that these kids have the resources available so that they can get back to learning as soon as possible, and then working with coaching staff and the athletic trainers at the local schools as well to make sure that they get back onto the field or on the court as soon as possible. So.
Yeah. I think most folks would think of one thing when they think about what we do, and that is the bread and butter of total hips, total knees, that kind of stuff. So anything you want to say about that?
Well, I mean, that's, if you think about rehab, orthopedic rehab is kind of the first thing that pops into everyone's mind. It's probably the part of rehab that the majority of our community has some type of experience with, either personally or with family. So from an orthopedic standpoint, we see acute and chronic pain. We also see those post-surgical patients. So it could be a total knee replacement. It could be a scope of some sort for ligamentous or tendon reconstructions. So yeah, kind of the bread and butter of
Sure.
rehab in general, but something we do offer.
Yeah, and we are very high on our own orthopedic surgeons here. However, some people do choose to have their surgeries other places, and I know you have a pretty good pipeline with other places in the around us where if you're a patient and you have your surgery wherever, we're still the ones that for most of those people that you do that rehab.
Yep, and it all starts with the relationship with those providers too. So regardless of where you have your surgical intervention performed at, we stay in close communication with that physician and their practice, making sure we update them on your progress, what your goals are, because we're going to see you much more frequently than the orthopedic doctor is going to. So the updates come from us.
Yeah. And then, speaking of these total joints, we have an inpatient rehab team that's not the only thing they do, but that's a chunk of what they do. You want to kind of talk a little bit about, if you're in the hospital, what folks of the rehab team they might see?
Yeah, definitely. So same as the outpatient side and with pediatrics, our inpatient rehab team consists of PTs, OTs, and speech therapists as well. When people think about inpatient rehab, like you mentioned, it's the total joint rehab that usually comes first to mind, but we see more than just total joints. So we can see patients with just general deconditioning. Maybe a patient has fallen at home, came through the emergency room, and they're not quite sure if they're ready to transition back home or they need additional help at home. So we'll see, fall prevention, neurological rehab. So if someone has a stroke and they're, same thing, working on that transition out of the hospital, we want to start therapy as soon as possible. A lot of research shows that the sooner we start the therapy, the quicker some of that function will come back. And so as a team, PT, OT, and speech, we can really attack that as quick as we can, maximize the outcomes, and get patients transitioned out of the inpatient setting as fast as possible too.
Yeah, good. And then we actually provide the physical therapy, OT, and speech for home health care.
Yes, yeah. So that's actually a newer thing that we've worked out over the last 6-8 months now, in that our staff that work on the inpatient side and even some that work on the outpatient side actually double as home health therapists. And what home health is for those patients that are having trouble getting out to the community. They don't have transportation, or they're just so weak or deconditioned that it's not a good option to come to outpatient. Home health therapists come into their home, they work on that general mobility, and then try to get them to be community ambulators as soon as possible, or community mobility as soon as possible. So what we found is that with that comprehensive team approach, so our staff are splitting between inpatient home health or inpatient, outpatient home health. Continuity of care is a little bit better. We can see those patients transition from inpatient to homebound to an outpatient setting.
Yeah.
And it just feels more family-ish, I guess.
Yeah. Our footprint's getting bigger too, in that the rehab team now is in Dixon and Morrison.
Yeah.
You want to kind of talk about that a bit?
Yeah, definitely. So same as what I was mentioning before, our vision for rehab, I think over the last 5 years, has been to develop this comprehensive department and also to improve patient access. That's the big thing. And so having a central location here in Sterling with the main clinic and the hospital was great, but we also realized we service patients from a variety of communities, and if you're having to drive to therapy a couple days a week from, let's say, Morrison or Dixon, Milledgeville, Polo, that obviously ties up a lot of your time. So in May of 2017, we opened our CGH Morrison Rehab Clinic, and then in January of last year, 2019, we opened up our Dixon Rehab Clinic. So both of those facilities are now staffed with full-time physical therapists, with availability as needed for OT and speech, so we can still provide that comprehensive care. And then one of the more exciting things recently is that starting the end of August, we will actually have one of our neuro PTs transitioning up to the Dixon Clinic, so that neurological rehab can also occur there. So traditionally that has mostly been done in Sterling, but we're trying to bridge that out.
When you say neuro, is that the big and loud?
Yeah, big and loud, power,
Okay.
or just like post-stroke rehab.
Okay.
Same thing, we want to improve patient access, we want to be available, and the closer we can get to the patients, the easier it is for them travel-wise.
Yeah,
So,
great. So if for those of you who've been listening through all this, I hope you get this sense that this is a pretty big ship, this rehab department, in terms of the stuff that's happening there. And I don't know about you, but until I got more involved with it, I didn't realize how much goes on there. So I'm glad we had a chance to talk about some of all the stuff that's going on, and I hope for those of you who are listening and will listen to this, that it opens your eyes like it opened mine, just to be more part of that team.
I would mention that for any of the programs we've discussed today, if it's something that you're interested in either learning more about or it's something you think could benefit you, talk to your physician, talk to your primary care provider. They can send a referral over for PT, OT, or speech, and then we can kind of communicate with you is the best way and where we want to schedule that and how we want to go forward with it too.
It might be even to chat with you a little bit,
Definitely.
just to kind of talk it through and see, am I a good fit?
Yep.
So if you want to get a hold of Jeff over there, we could probably put something up on our.
It's already there.
Oh, it's already up.
Perfect.
All right. Dane and Matt are out there. So all right, good. All right, Jeff. So that's I want to get an overview of the department, but on a personal note, I'm just curious what got you interested in wanting to become a physical therapist, and what it takes from an education standpoint to make that happen.
So I think, looking back, original inspiration for PT was injury to myself when I was in junior high. Had rolled an ankle, ended up going to some therapy to get back to playing sports as soon as I could. And at that age, it was the greatest job there could ever be because I could stay involved in sports, but also work in the medical field. As I went into undergrad and then into PT school, you learn that physical therapy is much bigger than just sports-related injuries, and and that population is fun to work with, but there's also a lot of other fun things that you can work and treat within the profession as well. So that's kind of where the original thoughts came from. As far as schooling goes, physical therapy is now a doctorate level degree, so you go off to your undergrad. There's not really a specific major or minor you have to have, but you do have to have an undergrad bachelor's degree, and then it's usually between a 2 and 3 year doctorate program after that. So total time, you're looking 5 to 7 years. There are a lot of PT programs out now that will combine your last year of undergrad with your first year of PT school. It's kind of an early fast track program. So that's where you're looking education wise. Occupational therapy is a master's level degree right now. So same thing, get your undergraduate degree and then go on to your master's level program. And they are actually moving towards a doctoral program by 2027. So following that same trend. And then speech therapy is also a master's level degree right now too.
Okay.
So
yeah, good to know. So the only thing that for those of you who have children, grandchildren, or you're someone who's interested in doing this, that my understanding is that if you go, there's these tracks where instead of going for 7 years, you can get it done in 5.5 or 6, because essentially you start, you're all crunched in from the minute you start undergrad or you start college. which sounds great, and as long as you're, yep, that's what I want to do, because a lot of students, their experience in college is that I like that, well, how about that? So they might change. If you're someone who is not for sure, and you're going to change your majors a little bit, that could get a little sticky.
Yeah, and usually once you're in these fast track programs, you're in it. You know, it's
You don't get to
no, and if you leave that fast track program, then you're kind of starting all over with phase one, which can be a benefit or it can be
Sure.
a disadvantage too.
Yeah.
And I would also say, if there's anyone out there thinking about a rehab, occupation, we work a lot with local schools and also colleges to either bring students in to do some observation with us, or contracting with actual PT, OT, and speech therapy programs so that the students can come back and do field work with our department. So you can reach out to either me or Human Resources Department here at CGH usually sets all that up for us. So.
Yeah, that's true. So do you have a favorite condition? Favorite problem you like to take care of?
As crazy as it sounds, I don't have a favorite. And I think, the preference is for me personally, is that generalist mentality. So it's fun to work on the inpatient side, it's fun to work outpatient, it's fun to treat and work with athletes, but it's also fun to see chronic pain, acute pain, and also any type of post-surgical stuff. So it's really the beauty of the profession in that you can specialize within our profession, or you can remain a generalist. And for a community hospital, a generalist approach is good. So yeah, don't specifically have a go-to right now. Yeah.
And I also know that you work with the sports teams in Rock Falls, right?
Yeah.
Okay.
Yes.
Yeah.
So I've been at Rock Falls for about 8 years now, as their sports physical therapist. What that job or role entails is obviously trying to prevent injuries before they happen, educating athletes and parents, and then also, if that injury does occur, being kind of the first person on the sideline to assess it and make sure that kid is taken care of as quickly and safely as possible. So.
Yeah, and I wouldn't be surprised if they also come to see you for the rehab.
Yeah, and same thing. It kind of bridges that that rehab in general. That started at the school, they need more formal, but then eventually we get them back to the coaches in the school as soon as possible, so they can get back to normal practice and activities.
All right, I'm going to segue into pandemic stuff, which is that I have a feeling you're not going to have as many opportunities to prevent injuries or treat injuries at the beginning of the school year as typical. So where are things at in terms of sports and that kind of stuff, Jeff?
Well, as many maybe know by now, Illinois Department of Public Health and the IHSA came out a couple weeks ago with some new guidelines for return to sport activities at the high school level. Essentially, in brief summary, they've taken the 3 traditional seasons of fall, winter, and spring sports, and they've divided them up into 4 sports now, or 4 seasons. And then each sport is rated based on a risk assessment. So the highest risk activities get to do the least amount of contact. The lowest risk activities get to do the most amount of contact. And then as trends within our community and region change, those tiers kind of fluctuate back and forth. So.
Yeah.
Not having football in the fall is probably the biggest change, and the biggest thing that I've heard. Football has actually been moved over to a spring sport for this school cycle here.
What month?
February is spring.
You might want to get some battery-operated socks and stuff like that.
Yeah,
for that.
yeah.
Oh my gosh.
Early spring.
My gosh. Frozen tundra. Whew. Okay. How's this pandemic affecting the work that you all do in rehab services, Jeff?
Well, I think like any either healthcare related position or just any work position right now, it definitely affects the day-to-day flow of things. Early on, when the mandate came out for the stay-at-home order back in March, we made the decision to temporarily close 3 of our satellite clinics, being the pediatric building, the Morrison Clinic, and the Dixon Clinic, realizing that would cause some access to care issues, but it was also the safest thing to do for patients and for our staff, make sure we had enough PPE to safely provide what we were doing. And then as we got a better feel for what was going on in the community, we gradually reopened those clinics, and now they're all open back up to normal capacity. So Day-to-day wise, just like any other CGH facility, we check your temperature, we do a symptom screen, masking is required. We're doing that for all staff, all visitors, and all patients. And we've been doing it long enough now that it is kind of second nature, but the goal is not to let our guard down and, you know, make sure that not only our patients and their visitors safe, but also that our staff are safe and we're able to continue to care for as many people as possible.
Yeah, good. I see Kathy out there.
Hi, Kathy.
And Jan, every once in a while, they're out there in the lobby and wiping down the chairs and making sure that everything stays clean out there in the lobby. And I know you guys, after people use the equipment, you're wiping it down every time and all those kind of things. Just to, I mean, it's common sense, but I mean, you're doing it.
Yeah, and from, you know, obviously washing hands, hand hygiene is really important right now. That stuff really hasn't changed much. You know, we were always foam in, foam out, wash hands before we were really interacting with the patient. We're wearing a mask and the patients are wearing masks, so that is a difference. But even from cleaning and sanitizing equipment, that procedure and policy really hasn't changed much because from an infection control standpoint, we want our equipment and the physical things in the rehab department to be clean between patients. So it is working with our staff, you know, to just make sure we turn over rooms a little quicker and that we're doing it as safe as possible. But
good.
Yeah.
All right, that's all I could. Yeah, that's good stuff we've gotten from Jeff. Thanks for hanging out with us, Jeff.
Yeah, definitely.
I want anything coming. Okay, so I just wanted to kind of hit a couple things about the pandemic. First of all, you know, our county's at 9.3 per 100,000, which is just a little bit lower than last week, but we're kind of about the same in terms of number of cases. So we're continuing to have cases. And hospital-wide, I don't know what number we were on in terms of positives last week, but we're at 161 now just for the hospital. Gosh, I think it was in the 140s? I lose track. But you know, you look in the county, and I think today it said there's like, I think we're averaging 5.5 cases a day in the county. So our hospital numbers are reflecting that. So yeah, that's still an ongoing thing. We continue to have patients that have COVID that we're taking care of here in the hospital. So yeah, I think in that regard, things just continue, and I just, as always, encourage folks to try their best to do the right thing everywhere they're at, because all that kind of stuff adds up. It adds up, and eventually the numbers start to go down if we can do that. So, thank you, all of you, for being part and listening, and share this with other folks so they can kind of hear. Like I said, I think that it was just really amazing to me to hear all the stuff that happens in the rehab department that you don't realize is going on. So keep that in mind, and hope you don't have to use it, but if you do, just know it's there.
Yeah.
And thank you for listening. Thank you, Jeff, for being with me. And next week, we're going to have a guest host. So next week, our CEO, Dr. Paul Steinke, is going to be joining. Actually, he's going to be sitting here. And do we know who's sitting there? Someone will be sitting there where Jeff is at.
No.
And and so just keep that in mind, and a little change of pace. And I look forward to talking with you all and having a conversation and answering any questions you might have in a couple weeks. So have a great weekend, and thanks for listening. Bye.